presenter today is Tim Perkins. Tim is head of our client delivery at DCS and leads our implementations of our care coordination solutions. I will have Tim take it from here.
Thank you, Laura. Good afternoon, everybody. Today we are talking about the HIPAA implications when you're trying to share information across the care continuum. Okay, so today this webinar is about understanding when you're trying to share information across the patient's care continuum, not yours, not mine, the patient's longitudinal care continuum. What do you need to think of in terms of HIPAA compliance? And it's not immediately obvious, so hence the webinar subject. So you're trying to share data across entities, we'll talk about that in a second, and HIPAA comes into play. Now this is not a HIPAA-only webinar where we're going to talk about all things HIPAA. We're not going to talk about the passage of the Act and all of that and all the different rules and regs. We're going to talk about the ones that are applicable to sharing information, interoperability, and implementing care coordination solutions in your world. So this is a subset of HIPAA. HIPAA is big and wide and deep. We're just going to talk about the pieces that bump up against when you're trying to share data and the things you need to think about. Okay? So as we said in our webinar description, they aren't diametrically opposed, HIPAA and sharing data across entities. There is some obvious tension there, but there are some things that we need to think about when we are sharing information, and that's what we're going to talk about. We're going to talk about what you need to think about, a little bit of background, and an approach that we think works to get it done. So we're going to talk about HIPAA requirements and impact. We're going to talk about some of the risks and penalties, just to remind you that HIPAA has a big set of teeth, some best practices to meet the requirements, and an approach, I think an effective way to go about identifying, understanding, and addressing HIPAA issues while you're also trying to stand up your other processes, your technical processes, or however you're addressing interoperability. A little background on us. We are a consulting and services firm that specializes in the healthcare industry around care coordination, interoperability, collaboration, and communication. How do we all work better together, more efficiently, more effectively? We have clients that are ACOs, clients that are large hospital chains, medical schools. They all try to figure out how do we work better and tighter together, and government agencies as well that we work with. So let's set the table a little bit. Let's talk about today's network of care. We all know there's a lot of actors in here. We have patients, we have hospitals, one of our acute care hospitals, we've got clinics, we've got pharmacies, we've got primary care providers, specialists, labs, insurance companies. We have nursing homes, rehabilitation centers, visiting nurses, OT, PT. If we all got in a room with a whiteboard, we could display them all over the wall. And the reality of it is that as much as we like to think that we can control how people interact, the network functions a lot like the brain. There's a lot of neurons that fire and a lot of possibilities that happen. So all of these people can interact with each other depending upon the situation, depending upon what's going on. So there's literally an infinite number of pathways, almost infinite number of pathways to that get involved here in the healthcare process, delivering care, getting it paid for, researching it, quality of care, treatment, etc. So it all depends on what's going on. So it's very contextual. And these pathways, I like to think of them as like the brain, neurons firing off, that they fire off by episodes. So when I go to the doctor, I make an appointment, I go to the PCP, I come in as a patient, he or she comes in and sees me, decides to tune up my meds or renew some of my meds. That goes to the pharmacy. I go get it, or it might be a mail pharmacy. They would mail it to me. A lot of different ways to go. And then the doctor bills, in this case, Medicare, and the patient may get billed as well, or the patient may partial pay. or the patient gets a summary of benefits. A lot of different things happen here. But in just a simple basic office visit, we're talking about a lot of these pathways firing off. And when it all happens well and on time, we get paid. Now, in this situation, we have the individual as their own entity. Well, we've got the pharmacy, we've got Medicare, we've got the PCP. What happens when you go to a specialist? Very similar, but it gets even more complicated. PCP has to have a referral, especially if you're in an HMO or an ACO. Specialist needs, if the referral happens, you go see the specialist. Specialist says, well, you need labs, so now they got to go put the order in for the labs. It could be owned by the company, or it could be like a Quest or a third-party lab. That information needs to go. Okay, so now you go to the lab, you get the lab test done, and again, everybody then winds up saying, how do I get paid? So that money goes up to the insurance company, the claim gets sorted through, and money comes back. Again, just a simple office visit with a specialist, especially if you're in a ACO or a PCP-centric arrangement. You're talking about 2, 3, 4 different entities being covered. And then the final one here just is hospitalization. A lot of the same players, but now you've got the hospital. And then within the hospital, you've got a lot. Now within the hospital is taken care of in the billing, but even then, just think of all that goes into a bill, all the different departments and all of those. That's all one entity. Think of all the work that goes in just to figure all that out. So, a lot of information flowing back and forth for a lot of different reasons, very contextual by the episode that the patient's going through. The patient, in many cases, dictates who delivers their health care and where it gets delivered. So you can't believe that you have complete control over where and when all that happens. It would be nice, but it's not. It's not reality. So we've got information flowing all over the place for different reasons, different times. How do we handle that, and how do we get ourselves covered from the HIPAA standpoint? So you could ask yourself, why should I share data across the entities alone? If I could control all of this, by my own insurance company, my own pharmacy, my own lab, my own specialist, if I was, and there are very few organizations that I know of that do this, but there are a few that are close, I would need to share data. That would be one big entity, one big happy family. I have to worry about the individual. Everything else I wouldn't have to worry about. But that's not the reality. The reality is you're already sharing data. If you get paid, you're sharing data because you're sending information, claimed information to one or more insurance companies to get paid. If you give or receive referrals to other folks, you're sharing data. Unless they're inside your ACO and you're a big group that all practices together and has your own specialties, even then you've got a patient that said, I don't want to go to Dr. Smith in the ACO. I want to go somewhere else. And there are rules about steering patients inside as opposed to outside. So you can't push as hard as you'd like to. You can make them pay in-network and out-of-network and all that, but you can't dictate. So if you give and receive referrals outside of your network or outside of your entity, you're sharing data. If you use pharmacies and labs and you prescribing, you're sharing data. If you've got a patient portal where you're putting information out there and you're enabling the patient to come in and look at their medical history and their records and their prescriptions and how much they owe and all the great things now that portals provide patients, you're sharing data. And all of this is subject to HIPAA. Right? And sharing for the most part is transactional based. Even if I'm looking at my medical history, what is my medical history? Mostly is a series of past transactions and changes. So all around individual episodes of care. So the question you have to ask yourself up front, and always asking yourself in any kind of interoperability program, is how are you sharing PHI with other organizations today? Do you know who? Can you identify? You say, yeah, I know exactly where my information is going and where it's coming from. And do you know how you're doing it? Because the HIPAA people do not care if it's written, if it's skywritten, if it's electronically sent, if it's sent to how it's protected health information, and it means you're on the hook to make sure that it's done, disclosed properly, managed properly, and also handle appropriately. We'll take a dim view on that. We'll show you some of the impact of in a minute on that. So, do you have a strategy? What is your strategy to deal with PHI and sharing? Do you have a business plan for sharing? Someone comes up and says, I want to share. The first question should be why, and does it make sense? Is there a business plan behind the initiative? Some of the projects that we do, we have to put together full business plans. Here's why we're doing it. Here's what we expect. Here's the quality. Here's the cost. Here's the reasons. And that all becomes part of a bigger business plan. Better to be on the offensive and proactive side of it than on the defensive side of it, reactive. So let's talk about some of those key HIPAA requirements that rub up against interoperability that we have to deal with. The heart of HIPAA, and we're not going to go through all of this, but there's two key things we have to kind of get centered when we talk about HIPAA, and that's the privacy rule and the security rule. And the privacy rule basically says, look, how are you going to use and release protected health information, right? So how are you going to get information that governs the disclosure, in other words, the privacy practices, things the patient needs to fill out when they come in? How are you going to use the PHI? Who are you going to use it with? Who are you going to send it to? Why are you sending it? And so certain rights, and these are civil rights that the patient has, is look, I can get my own PHI if I want it. I can choose to say yes, share it with my wife, my husband, my friend, my landlord, whoever it is that you think might help you get better health care. The security rule is basically how it's protected. That's more physical, that's more chain of custody, that's more, what are my rules for protecting? And those break down into administrative, physical, and technical. So, physical, where is it? Is it in a locked? Is it in my patient files? Is it in a separate room? Is it locked? If it's online, do I have passwords? Is it encrypted? How is it moved when I move it electronically? There's a whole set and host of information which specifically governs that. So it's not a very quick example. If I'm going to move information, it needs to be encrypted on my laptop when I have it, or on my computer. It needs to be encrypted when it's moving somewhere else. It needs to be sent through a secure pipe connection. I just can't send it over Comcast out in the open. I just can't send it in an email, for example. And then it needs to be encrypted when it hits the other end and is stored in the other end. So these are all part of the technical things. These are all part of the things that get into the infrastructure component. But for our purposes, it's enough to just remind you that there's a whole bunch of other sets where you start getting on the technical leg of this. And there's also a big administrative leg to this. As a matter of fact, most of HIPAA is administrative more than physical and technical. So there's a lot of other security standards, and there's a lot of different organizations, and that's what we're going to talk about now. From the one doc to the 1,000-bed hospital to the guy who comes in and physically shreds your documents. He's involved in HIPAA as well. So this is why we have to kind of really understand who we're touching, why, who they are, and how I need to relate to them. So we start talking about relationships. There's basically two basic types of relationships, and there's two others, but the two you're really going to use the most is how you regard these organizations. Are they covered entities, or are they business associates? And we'll talk about each one in detail. But covered entity, in short, is the healthcare organization. It's somebody who's hands-on the patient. So a physician is a covered entity, a specialist, a hospital, a skilled nursing facility, visiting nurse. These are the people, the dentist, the chiropractor, people who physically hands-on the patient, applying their healthcare training. These are covered entities. There's a whole set of rules around a covered entity. Then there are people who provide services to those covered entities, They aren't a part of the organization, but they supply services to them. So a good example is if you've outsourced your medical coding. Now the company comes in, they do your medical coding. Great. What do you need to do? You need to send them an awful lot of protected health information in order for them to do their job. Do they belong to you? Do you own them? No. They're performing a service that's essentially a subcontractor to you. So they are a business associate. In the line of their job, what they're doing for you, they need to see protected health information. So we'll go through these scenarios, but you've got covered entities, and you've got a business associate, and you need to have an agreement with the covered entity. If I'm doing medical coding for the hospital, then I need a business associate agreement with the hospital. And it means that I will take responsibility for the protected health information. I will do all those administrative and technical and security guidelines that you need to do up at the hospital. I need to do down in my organization as well. I will take care of your information. Now, business associate agreements can also have agreements with other business associates. So if I'm the medical coding company and I have a business associate agreement with the hospital, I may in turn have all my information with a hosting company. I don't have servers in the back room. I have servers in the cloud. But I have HIPAA compliant servers that I buy from a hosting company. Well, that hosting company is taking that protected health information and they are storing it, manipulating it, and not using it per se, but they are touching it as they do what they do with it. So as a business associate with the medical coder, I need to have a business associate agreement with the hoster because they are touching PHI on my behalf, which I am then coding on behalf of the hospital. So you just got to kind of follow the train right down and anybody who's touching it. And there are some exceptions. For example, the Postal Service is not a business associate because they physically take a sealed envelope of information, move it from a place to place. So I don't need a business associate agreement with the post office to deliver bills and test results. Likewise, in the electronic world, I do not need a business associate agreement with what's called ISP, Internet Service Providers, if all they are doing is providing connectivity, moving things place to place. I do, however, need to make sure that when I do that, I'm doing that in a secure fashion. But they're just kind of like the post office. There's very few exceptions. When anybody else is touching PHI, you got to take a hard look at them and see what they're using it for and what they are. And probably the most bizarre situation, a covered entity can also be a business associate. So if I am a hospital and I have a big coding group that I own, that's great. If I if I sell some of my excess capacity of medical coders to another hospital, then in fact for that relationship, I'm a business associate to the other hospital, even though I can also be considered a covered entity in that world. So it's very situational. What services are you providing to whom? So we'll get a little bit more into that. So I want to remind everybody here, because some people are varying states of acceptance or denial about HIPAA and PHI. And here's a pretty comprehensive list of what protected health information is, right? Simple stuff. Every time you go to the doctor, what's your name, what's your date of birth? Everybody thinks that's it. No, it's about 18, at least. You get names, you get all kinds of dates, anything that can tie you to you, can be used to identify you. ADT information, dates, address information, excuse me, age is a big one, postal address information. There are some exceptions there. For example, I can identify people by state. I can identify people by zip code if there's over 20,000 people in the zip code. So there's some, little exceptions here and there, but for the most part, when you're thinking about this, you're doing your planning. You can't use zip, you can't use phone numbers, fax numbers, social security numbers, medical record numbers, license numbers, vehicle identification numbers. I've yet to see that in an EHR system, but who knows? URLs, especially if I've got home internet. Everybody has a IP address that identifies their house and their machine. Biometric. So anybody with an iPad 6, you've got those little fingerprint things. All that. And the other interesting one is photos. We did a project recently for a client that involved photos, so we had to be very careful. That was PHI. So be very careful about that. Not something that people automatically think about. So in general rule of thumb is if it's a piece of information that can be used to identify that the individual, the patient, probably PHI. So if we go back to this, again, to illustrate our point, here's our network where we've got all kinds of transactions flying around. If we take the covered entities, these guys here are the covered entities. They're health plans, they're doctors, clinics, nursing homes. They're delivering the goods. These are the guys in the front line. This is a covered entity. If you go underneath the covered entity and kind of wash them out a little bit, you're going to find a whole bunch of other people. You're going to find labs. You're going to find lawyers, hosting companies, medical codes, all kinds of administrators, consultants, technology vendors, shredding and document destruction. All of these people are performing services for the covered entities. They are third parties. They are separate entities, but they need to see, touch, and have access to protected health information in order to do their job. So you kind of twist things around a little bit, and you really have to start thinking about, chain of custody, access, when you start to think about sharing data. The other thing is when we're looking at, we go back here for a couple, we're looking at covered entities, there are a couple ways people can consider covered entities. In this one here, I've got 2 hospitals. What if those hospitals belong to the same group? If they were owned by a big healthcare organization, they were owned by Kaiser or Tenet or Partners or Vanguard or, Vanguard's not part. But anyway, what can you do then? Are they still 2 separate entities, or can I just say, you know what, they're really one? We kind of treat them as one because they're really 2, they're not 2, right? And that's what these entity organizational relationships are about. There are different ways you can, when you look at your map of organizations you deal with, you can then begin to reduce it or simplify it by looking at how these groups relate to themselves. So there's a couple of big ones here. One is called an ACE, affiliated covered entity, and that means that I've got all these legally separate covered entities, but they're affiliated, and they're controlled and owned by one group. Common ownership, common control. If I can prove that, then I can just say, look, it's all one. The best example up here in the Boston area is Partners Healthcare. They've got, if you look at their privacy statement, their privacy requirement that patients need to sign, they all need to sign the same one. And when you look on it's a 4-page form. 2 of those 4 pages list at least 25 different entities that belong to partners that say, yep, you know what, we're all separate entities, we've got different hospitals and all that, different physician groups. And you know what, for our purposes, for HIPAA purposes, it's one entity. It's just called Partners Healthcare. And there are some things that partners need to do as a result of that. They need to prove they have common ownership and control, and also they need to use standard release forms when the patient comes in, no matter whether they're going into Mass General Hospital or whether they're going to Cooley Dickinson out in Amherst, Mass, or up that area. And they all sign the same one. So that makes our life a little bit simpler because it allows us to pull the people that we deal with into bigger buckets. And I'll show you why that pays off in a minute. So that's an important thing to understand. Another one is this concept of an organized healthcare arrangement. which is very simple. The best example I can come up with is let's say you've got a university. The university has a hospital. The university has a medical school, and the university has physicians and groups that work for both. And okay, we have one of our clients in that situation. Well, in that situation, they can say, you know what? Even though we're really separate entities, medical school's one entity, the hospital's another, and maybe somebody else, maybe a couple other players in there, and a bunch of different physician groups. For purposes of what we're doing here, can we just kind of call all that one thing? And the answer is yes. You can. There are some things you need to do, but you can pull them all together. So when you're starting to do your map and what you're doing, it's not only important to understand who you are, but also who you're dealing with. So, for example, if most of my world, in that situation, if most of my world is all of these guys, this is affiliated with the, what's the color here? If these guys are affiliated with the university, and these guys are, and these guys are, and these guys are, and these guys are, great, I can just say, you know what, it's all one big thing, one big family. And I don't have to worry so much about HIPAA information inside the family. I still got to worry about the pharmacy, and the insurance company, and this rehab center here. They're really good, but they're not really part of my group. So, all right, that's okay. That works. So these things were an addition to kind of simplify things a little bit. HIPAA and simplification, kind of an oxymoron, but it does work. And then finally, we have our friend, we have the business associate agreement. That's fairly straightforward. You just basically, it's a contract, and you are putting the person who's working and the people in the organization that are working for you on the hook to say, I will do all those things I'm supposed to do administratively, organizationally, in order to make sure that I'm doing the job and that I'm taking care of your PHI. There are a couple less frequently used arrangements. And one is called the data use agreement. And that's really mostly around research. So let's say I'm in a university setting, I've got a medical school, a university, and a hospital, and somebody wants to do some research. And to do the research, they want clinical information from the hospital. Okay. Or you're participating in a pharma study. The hallmark of those is going to be called the data usage agreement, which says, look, we're not really using the information to treat patients. We're using the information for research purposes. And then what you're going to pass along is what's called the unlimited data set. And what that says is we're going to strip out as much of the PHI as possible, protected health information as possible. For purposes of my study, I don't need to know where you live. I want to know your age. I don't need to know your name or MRN. So there's certain subsets of information that are relevant to my study. In some cases, zip code might be very important if I'm trying to do, cancer rates in certain areas, things like that. It all depends on the study. The idea is you strip out everything you can strip out on protected health information. You de-identify, you go to a limited data set, and then you do a straight one-to-one agreement that says, here's the information that we're going to give you, here's why we're going to give it to you, here's what you're going to use it for under very strict circumstances. I can use it for this study, but I can't use it for fun things. I can do certain things with it, but that's all I can do. If I stray outside those lines, deal's over, give me my data back. And then you've got trading partner agreement, which is more of a technical, it's mostly has to do around Medicare and the information going back and forth. A lot of third parties getting involved in Medicare, people who send out the coordination of benefits letters and health claims and things like that. And that's, just so you know about it, it's relatively rare. It used to be more in place before the most recent changes in the last couple of years. The High-Tech Act was made on HIPAA. So, you hear about a trading partner agreement, it's most of the time when you used to use a trading partner agreement, you're really using business associate agreements now. So, it's very limited, one of those exceptions that proves a little type of deals. And then the kinds of transactions we're talking about. We're not talking about the trading partner agreements, anything that's directly impacting the care of the client, except potentially the referral certification, but it's mostly back office stuff. And this just as an example of what's in a data usage agreement, it's just very straightforward. There's all kinds of sample ones out there that you just got to say, I'm going to give you the data, here's what you're using it for. You're not using it for these things, you're using it for these things. Might not see a lot of that, but just so you're not throwing someone says, oh, what about research? But here's the good news. It's probably the best news in our presentation. The covered entities can share PHI without worrying about too much. You still need to disclose it properly outside to the individual. You still need to respect all of that. But with each other, in the family, cross-covered entities, go ahead, knock yourself out for the purposes of treatment, payment, and healthcare operations. Right? So if we're dealing with treating a patient, and you're a covered entity, and I'm a covered entity, let's go. Let's share the information on behalf of the patient. Let's get them well. And so what we mean by that, treatment's pretty straightforward, but the government, they got to define it anyway. How am I coordinating care? How am I getting paid for it? That includes information on this patient's previous insurance information, deductibles, all those, plan what they're eligible for and what they're not. And then the umbrella is this thing called healthcare operations. So, quality reporting, a lot of hospitals, a lot of organizations need to do a lot of reporting to a lot of people because they're getting all kinds of federal funds here and there, and probably together. And there's a lot of incentives out there, as we all know. So a lot of information needs to go upstream to somebody, and this basically covers that. It also covers public health registry reporting. There's some notable exceptions like abuse and things that have to be notified immediately. So underwriting insurance companies, just think of this as the big other bucket. It says, look, in the course of doing business, I'm going to need to share information with other covered entities. So that's really good news, right? And you can't forget the patient and the family. They kind of have their own set of rules, but everybody's pretty comfortable with those now. You need an individual rule, an individual private, you have the person, the patient sign off on the policy, privacy policy, and which nobody reads, but they just sign. And then you also have to be careful about sharing information with family members, of course. And in projects that we've done where we tend to expand the discussion and the engagement of beyond the patient to the patient's caregivers and family and support network around each patient, we have to be careful to make sure that we get authorization by the patient. We do this in writing to say, yes, you can share information with my landlord upstairs because she's the one who gets me to my appointments, right? So can't forget the individual. They're kind of in the universe by themselves, and rightfully so. And then there's some information around that. So in all this entity talk and what type of entity and the relationship, you got to remember the patient and the family. So just a few minutes on risk and penalties. Just so you know, this thing has teeth, okay? HIPAA is considered a civil right. It is my civil right that people will not throw my protected health information around, sell it, to other people, and just treat it carelessly, and just throw it out there. Stolen health information now is worth a lot more money than stolen credit card information these days. There's so much more you can do with it. So people want it, people are after it. So you can't treat it carelessly. So if you have violations, unknowing violations, I didn't realize that everybody should encrypt their hard drive, and then they do investigations. It's 9,000 investigations a year. That's like 25 new ones a day, 7 days a week. And if you think that it's kind of like an IRS audit, if you think that you it'll never happen to me. Well, most of this stuff comes through patient complaints and whistleblowers, disgruntled employees, people saying, "Hey, you know that they leave the doors wide open, or you know that they walk around with medical records in their trunk. There's the laptops sitting in the car and they're not encrypted. All kinds of things happen. So when they do the investigation, they take all this into account. And if you've done the right steps and you've shown a good effort and you're not doing this maliciously, they could first case, all of that. There's some scale in here that they can use. So, unknowing $100 a violation, reasonable cause, 1,000, willful neglect, like I've never done a risk assessment, I've never done a risk audit, we never lock our doors, everybody's got their password still sticky right next to the machine, encryption, what's that? Then they can really come down on you. And they can be up to $1.5 million a year. So this is real teeth. And they're not afraid to have you write the check. You can also have criminal penalties. If you're doing this because you're working in a doctor's office and you like to take a couple of credit cards off once in a while and do some shopping on your own, okay, well that's a crime. So let's go after you. If you're taking it and selling it to somebody else, that's a crime. So in every breach, they got to look: is this kind of just a civil infraction or is it a criminal? It's kind of like criminal court, civil court, but they have the leeway to go either way. So we're talking about some real teeth here. And just 4 quick examples, 3 quick examples. A hospital someone had a laptop, 3,600 patient records, got stolen, wasn't encrypted, 3,600 patient records are out there. $1.5 million penalty. Hospitals in Idaho, 441 records, $50,000. Another stolen laptop. And then my favorite was a health plan that was fined $1.2 million for not wiping the drives out of their photocopiers, which contained 350,000 health records. Unfortunately for them, it was the photocopiers, huge photocopiers off of lease, were purchased by, I think it was CBS News. It was a news company. And once they saw this, they said, oh, we got a story here. So it was a big black eye. And it was a $1.2 million black eye. So it's out there and you got teeth. So, and you've got a breach, if you've got there's different levels of breaches. If it's 25 records, you got to report it. You got to report at the end of the year. Different levels, different breaches, all that's covered in HIPPA. But if you have a breach and you don't report it, you get caught not reporting it, you're in trouble. And my other favorite one was a doctor retires, someone from the office drives by and leaves like 3,000 medical records that belong to the doctor in his driveway and drives away. That was also a hefty fine. So these things happen every day. So what can you do about it? All right. We'll take some questions. First thing is you've got to map out your relationships. You've got to figure out what's your network like, what's your world look like, what's your interaction, and who are you dealing with. Are you dealing with a bunch of covered entities? Are you dealing with one big covered entity most of the time? Who needs a business associate agreement, business associate relationships? Are you having business associate agreements with covered entities? Are they doing some service for you on the side that's not really part of coordinating treatment or the things covered under covered entities? Covered entity is covered entity. Are they doing research? You need a data usage relationship. So, our philosophy is first thing you do, you sit down and you map out your relationships. You say, who is it? What's the relationship to me? If you can, what kind of workflows? What do I exchange with them? Is there any kind of, how am I doing it? I mean, if look at the nursing home, it's a covered entity, great, and I'm sending CCDs via fax. Okay, happens every day. That's okay. still needs to be recorded, still needs to be dealt with. I still need, to understand it's a covered entity. And I need to deal with it. It could be secure facts and all that. I need to make sure of that. But I need to have that relationship. The Bayshore Hospital is a covered entity. They're using an HIE. Well, the next question is, what's my relationship to the HIE? If I'm putting information in and out of the HIE, what do I need? Well, the feds say you need a business associate agreement with the HIE. And that could be everybody who goes in and out does one, or it could be all one together, but you need a business associate agreement with the HIE because they're handling your information. And it's more than just the post office, because they actually have to open it up and look at it in order to figure out who it goes to. So you got to go through this. You got to go through every one of these. You got to go, hey, Quest. What's my relationship to that? So our recommendation is you got to go through. You got to identify them, and then what the relationship is. So then you use your map as your guide. You may want to prioritize by risk. You might say right away that, you know what, you don't have any agreement in place with this guy and this guy. You better hurry up and get one. Some of them you might have an outdated relationship with. Some of them you might have started faxing, but now you've hooked them in, you're feeding them through the HIE. Well, that's a little bit different. So you got to do some prioritization by risk. And then each relationship. What is it? How do I address accordingly? If it's a covered entity, it's a covered entity. If I've got 5 hospitals and I belong to one ACE affiliated group there, great. That's easy. I can check those 5 hospitals off the list. Who's my document shredding guy? Do I have 1? Do I have 5? Maybe I want to consolidate under 1 to make it easier and have 1 business associate agreement. Every one then winds up becoming its own little story, its own different scenario. And, don't forget the patient-family rules in this. Wherever applicable, wherever these people are reaching through the individual, you got to keep that in the loop as well. The other thing I would recommend is make sure your own house is in order. Make sure that you're doing your thing. So, for example, one thing for sure, you've got to do security risk analysis. The Fed's number one thing when they come in an audit, they say, show me your security risk analysis. And most people don't have one. They haven't done it. You got to have one on file. Even if you have a problem, show that you were able to identify the problem and that you're working on it, you're addressing it, goes a long way. And they're saying, you know what, we've never done it. So basic things on your HIPPA side you can do proactively. Then you've got to do the work. You can implement that, the documentation, the policies, the procedures, the privacy policies, business associate agreement, the notice of privacy practices. Most of this is administrative. So it's not glamour work, but it needs to be done, and it is a huge vulnerability, and will slow up your data sharing efforts, or come back and bite you, usually at the worst possible moment. And you got to get everybody, you got to get the right people compliant. And just as a side note, my best advice, probably one of the best pieces of advice I can share with you is encrypt. Encrypt, encrypt, encrypt. Most of those cases we went through earlier, with the exception of the photocopier, wouldn't have happened if those laptops that got stolen, if those hard drives were encrypted. Easy as that. And today's, with Windows and Mac operating systems, you can easily encrypt AES 126, 128, all the 256, AES 256 encryption happens right away, happens automatically, you don't even think about it anymore. Someone steals my laptop and I've got the password thing on it, and it's encrypted, and we're not in breach. We've got a number of business associate agreements. That one thing alone, simple, easy, people overlook millions of dollars because people don't encrypt their hard drive. So just think of that as a side thing. So in summary, it's critical. You're already sharing information. It's just going to get bigger, wider, and deeper. So let's get on top of it. And it's about the patient. The patient's calling the tune. Maybe over time, as ACOs take over more, and you're able to corral more people and keep them in the theoretical network and the actual network more and more, this becomes less of an issue. But we know that you're never going to get to 100% of that. So really understand who you're dealing with, who you're playing with, who you're sharing information with, what the relationship is to you. So it just takes some thought. There's some plotting that goes along with this. There's some thought, some planning, and some management. And like I say, it may not be exciting. It's mostly administrative, but it's a critical leg of accomplishment. In fact, anybody who's involved with an HIE, I'll tell you one of the worst parts of it is getting all the agreements done. And understanding the relationship and who's going to share what with whom and how it's going to be done. The technology is pretty much figured out. You got HL7, you've got Mirth, you've got dedicated VPNs, you've got all this stuff is there, and it is done. The technology, in fact, is probably the easiest part of it. It's doing the planning up front, doing the administrative part, understanding relationships. So establish your maps, address each one accordingly, and be proactive, because the best breach is no breach. That's the one that saves you money, gets you where you're going, and gets you off what's called the wall of shame, which is the public reporting, which is done up on the government site, which has every breach on it. If you want to get scared straight, go out there and look up the wall of shame for HIPAA and take a look at some of the circumstances, and that will wake you up. So I'm at the end here. Time for questions.
Here's one question. How quickly do I need the BAA in place?
Before you start sharing information. So it's not like, well, you got 30 days. No. It's supposed to be, we're going to send you information, you're going to send us information. You're doing this service for us, and it should be part of the contracting cycle. And if you're dealing with dealing with an organization that doesn't know that, and they're in the business like shredders or medical coders, to overuse that example, then you've got another question to ask yourself, because if they're entering into it without insisting or bringing up the subject of a business associated agreement, that means that they might not know what they're doing. Or they could be opening themselves up to a huge liability.
Great, thank you, Tim. I see another one came in. I'm confused about whether a SaaS or software as a service vendor needs a BAA as well.
Yes. Don't be confused. The answer is yes. When the new changes came into place in the high-tech law a couple years ago, there was a big debate. And you had hosting services that said, we just host it. They just store it here. It's like, I just put my golf clubs in my friend's garage. Well, the Fed said no dice. If you can get to those golf clubs and you're going to manage them and you're going to look at them, you can get at them, then you have access to them. So you need to have a BAA in place. Like I said, the only real exceptions are the post office and an ISP. And the ISP isn't providing hosting. All they're doing is connectivity. And even then, you got to make sure you're set up with encrypted VPNs and all that good stuff, and that it's going through encrypted. So they're just handling encrypted packets. They don't go into it at all. So the answer is yes. Unless you're a straight ISP or the post office or FedEx, you need a BAA. They're handling your PHI.
One more. I've been told I need to review this with my compliance officer. What do they need to know?
They're going to ask all the same questions that I did, and then some. And so my suggestion is you need to get them involved early. You need to take that map and share that map with them for a couple of reasons. One is that they can give you some good guidance. And two, they may already have BAA agreements in place with many of these people. especially when they're already doing business with us. And then the question is, does it apply to what we're doing to them? So if we're getting one service from a company and somebody else wants to get another service from the same company, chances are the business associate agreement in place should work, unless it was so narrowly cast at the beginning that the new service is outside of the original agreement. But it needs to be looked at. Eventually, this all needs to go through and coordinated with your regulatory people. They are on the hook. You cannot sign a business association agreement without them getting involved. So you just can't go off and freelance and do your own thing. So they need to be involved early and often. And they know what they're doing. They'll give you some good guidance.
Thank you, everybody, for joining us today. And if you have any further questions, please reach out to Tim. Thank you for joining us today.